This conference will now be recorded.
So, welcome all of you to the class, and it is the most requested topic. So, like today, I'll be doing consent and ethics, very important for part 2 and 3. And like these are the few things I'll be covering. First, I'll be just speaking about it. After that, there will be question discussion. And anytime if I'm not clear, you guys can stop me. So, what are the types of consent? First of all, there are three types of consent. Implied, when you ask for blood test and she holds her hand, she holds her and she stays still. That means without even saying yes or no, or without even writing anything, yes, she's agreeing for it. So it is implied consent. Another is verbal expressed. For example, you ask patient that yeah, she would require examination and she gives you answer yes and or no. So that is verbal expressed consent. And last is written consent that everybody knows. Okay, so it has to, so there are three types: implied, verbal expressed, and written expressed consent. Okay, now, first I'll be covering this because it is very important for part 2 people and part 3 people both to understand, After that, if the role player asks you any question or if any question come in part 2 exam, it becomes easy. Okay, this is important for mainly for part 2 people because part 3 people need not to know this number. Directly you will get SBAs from here, and this term, this numerical ratio, and this description is important because a question comes from anywhere. So very common. 1 in 1 to 1 in 10, a person in the family. Okay, family usually have a group of 5 to 10 people. Important to remember. Common will be 1 in 10 to 1 in 100. Person in a street, when you roam about, so you can see 100 people. Okay, uncommon, 100 to 1 in 1000. Person in a village is a small place. Okay, so 1000 people can be there in a village. Rare is 1 in 100, 1000 to 1 in 10,000. So rare, it becomes in 10,000s. Person in a small town, very rare, has to be less than 1 in 10,000. Okay, less than 1 in 10,000. So like it will be so it, I think it will be, it should be lakh. Very rare. 10,000 they have written. Okay, so it is less than 1,000. So it will be like a person in a small glass town. So what can be done? I try to make the thing a little easy so that you guys can remember it. So like if you just see it in this manner, like because remembering this sometimes it becomes very difficult. So if you can remember the last part of it, then you just do -10, then this number will come. So very common is 1 in 10. Okay, if you divide, if you make 10 less, so it will be 1 only. So very common, just remember the last number. 1 in 10, common 1 in 100, uncommon 1 in 1000, rare 1 in 1000, and very rare will be less than. It will be less than 1 in 1000. Okay, so this way, like it becomes a little too easy to remember. It becomes a little easy to remember. And if you want to get this number, just do from the like denominator 10 less, so this number will come. Okay, so just remember this last part, so your whole range you'll be able to remember. Another way, what you can, how you, it can be remembered is common, very common, and uncommon. So it is they are the multiples of 10. 10 into 10 into 10. Okay, very rare you can remember easily. Like rare will be 10,000 and very rare will be less than 10,000. Okay, so only one number you have to remember in very rare column. So this way, the things becomes easy to remember, because this table is important for the part 2 people, not for part 3. Though sometime role player also asks some number, but not too much. So this way you guys can remember this number, and you will get questions. Sometime you will find a question, what is a very common, so there will be these are the options, so you have to choose a person in a family. Sometime they will give you this number. This is like 1 in 10 to 1 in 1000, what could be the like term, so answer will be uncommon. So for part 2 people, this and this all uh, like numbers, abbreviation, or every part of the table there will be questions, so you have to ask. So this way I sort of try in multiples of 10 to make it a little easy. For part 3 it is not that important. Now coming to pelvic examination. So what is the requirement? There should be the chaperone should be there. So a chaperone, is a person, like he all present during the time of examination. So like making the patient a little comfortable, or for a sort of a help. Okay. So it is very important, for part 3 also it is very important. When you say I would like to examine you in the your stations, you have to call chaperone, because it is that would be the count for the patient safety. Okay. So it not for pelvic examination, for all examinations chaperone has to be there. So what is the requirement for pelvic examination? If you have to do, chaperone should be there. There should be verbal consent. Okay. And like it there should be, it should be recorded in the notes. And consent, when it is taken from the patient, it has to be specific, like whether you are going to do as a clinician or vaginal examination or rectal examination or both. So this is the requirement for pelvic examination. Okay. So chaperone plus verbal consent with a clear explanation to the patient what you are going to do. Very important for both part 2 and part 3 people. You have to explain to the role player what you are going to do. Then coming to breast examination, usually there is no evidence that routine breast examination is required for pregnant women or in gynecological practice. So we are not doing it, because even the sometime question I have seen from this part also. Apart from this, if anyhow for any reason breast examination is required, then verbal consent and chaperone, two things are required. Okay. So that if you have to examine breast in mastitis station of part 3 station, you have to ask for chaperone, you have to take verbal consent from the patient. So this way application of this knowledge is done in part 2 and part 3. Now for OPD procedures, written consent with documentation, for example, like diagnostic hysteroscopy or any daycare procedure when it is done. So written consent with the documentation has to be there. That is a requirement. Apart from this, patient can withdraw her consent at any moment of time. Okay, because usually these are the OPD for any procedure. Consent, it's patient choice, it's patient right. Consent can be withdrawn at any moment whenever she wish. Okay, so this also you should know. Now ultrasound is done during pregnancy, so written advice has to be given. So it is not that patient is coming and we are doing ultrasound. Always there is a written information, written advice is given, then the ultrasound is done. But written consent is not required. Okay, only we are giving some sort of a leaflet or giving advice like what this ultrasound is. But to go for ultrasound, written consent is not required. Okay. Now this is important for part 2 people mainly. So consent of the patient, explicit consent of the woman is required, because during teachings medical students will be there. So verbal consent in gynecology consultation and obstetric consultation, operating theater, if students have to observe or they have to assist, or while performing clinical pelvic examination, so verbal consent will be okay. But if like pelvic examination student has to do in an anesthetized woman, then written consent is required. This part is important, you should know. Part 2 question comes from this line. Now, what about multimedia images? Usually, multimedia images are taken as a part of endoscopy, radiology, sonography. We are taking it, and they are recorded and stored in the hospital data. Okay. And like whenever these laparoscopic, ultrasound, or X-ray, whatever we are taking images, like additional consent is not required for this. Okay. But if same thing is being used for the purpose of education and teaching, written consent has to be there. That means without the written consent of the patient, all this images that are captured while doing a patient surgery or a scan cannot be used if the written consent is not taken. So it is important. Apart from this, there is a what they say, because of the unregulated natures of the images outside the secure environment of the hospital servers, images of interest on the smartphones or mobiles cannot be taken. This is important mainly for part 2 people. This can come as a question. So if it is taken in the hospital thing, like hospital machines, hospital recorder, and they are kept, it is fine, no special consent. But if they are used for any educational teaching purpose, there should be written consent. Third, no picture can be taken on the smartphone. So you should know this. Apart from this, now coming to tissue samples. So if patient has come for any kind of surgery, for example, hysterectomy, oophorectomy, the tissue, the sample is removed, and then it is sent for the histopathology. Specific consent is not required, because when the procedure is being told, so that part is covered. But if any part of retained tissue, like for specimens or anything, if they are used for education and teaching purposes, in that particular situation, uh, like consent has to be taken. Without consent it can't be done. Like for example, in stillbirth also, if a fetal part or any like any fetal part, it is being used for any research purposes, any test purposes later, teaching purposes, then written consent is required. Even you guys, if there is a station in part 3, when you have to take consent for IUD post-mortem, that time there is a column in the post-mortem consent, that like a patient can agree or disagree for keeping fetal tissues for purpose of research and teaching and research. So there is a special column for that. So if it is required, then written consent has to be taken. So that part is very important. Now coming to what obstetrics. So like when if for anything consent has to be taken, so it has to be taken when the patient is comfortable. So in between contractions it can be taken, in between information can be given in between contractions, because anytime you want to do vaginal examination, or episiotomy has to be given, epidural or anything, for anything the consent, you have to give her information. So it can be given when she's pain free in between contractions. On the other side, if she has effective epidural, then there is no problem, she's comfortable, consent can be given. Now another few things important that it should be important. So like for any if any emergency procedure is done, then it can be done with the verbal consent only. If it is too much emergency, but for the interest of mother and baby, so verbal consent, with the verbal consent it can be done. But if any procedure is done under general anesthesia or regional anesthesia, written consent is must. If you guys must have gone through your operative delivery guideline, when they are shifting the woman in theater, that time they are taking written consent. But if they are doing that operative delivery in the labor room itself, or labor room itself, that time verbal consent will be okay. Okay. Apart from this, if the emergency situation is there, so verbal consent can be taken, but it has to be witnessed by another professional. So obstetrician and witness to verbal consent must record the decision and reason. Also they have to write the reason because they proceeded to emergency delivery or anything without written consent. So whole situation means if there is an emergency, you have to, for example, take a patient to any procedure, and you are the patient is not in a position to give any uh, written consent. So it can be done with the verbal consent, but it has to be witnessed by any other care professional or doctor. Okay, but and the witness and obstetrician, they have to record their decision and also the reason why, without written consent, that emergency delivery or emergency procedure has been done. So this part you have to understand, because they would give a scenario, there would be an emergency and you have to take this patient for emergency delivery. So you make there would be an option that it has to be done with a verbal consent. So maybe this will be an option that it can be done in emergency situation with verbal consent, but it has to be witnessed by another care professional. So you guys have to understand this, because there are many scenarios when you have to give the answer. So this understanding is very important. Apart from this, if patient has capacity, very important, this yellow lines are, if patient has capacity to consent and she is refusing for cesarean section or she is refusing for assisted birth, even after you explain about the risk benefit to her and her baby, her wishes has to be respected. Why it is important? Because fetus inside has got no legal right. So even if she is choosing an option that will lead damage or death or any problem to baby, you can't force her, because baby has got no intrauterine fetus has got no right. So whatever will be done, it will be done with the decision of women only. You will find a lot of scenarios where there will be a very long scenario and they will say patient has capacity and she all risk and benefit has been explained and she is refusing for assisted birth or cesarean section. And okay, in that particular situation, answer will be respect her wishes, because if her patient has a capacity and if she is refusing any treatment that is important for her or her baby, so you can't force her. Her wishes has to be respected. So it will be very important that you guys should understand that, because woman with capacity has a right to take decision for herself, whether she can use any suboptimal option that could be harmful for her or her baby. It's her choice. You can't force her. So is this part clear? Is this part clear? Because this is sounds to be a bit difficult if you have not done lots of question. Any questions till here, or should I go ahead? Any question? No question. Okay. Now to apply principle in the obstetric so it is the same. Okay, so a woman who don't does not lack the capacity but they are in pain, if they are in pain, you can't think that they are incompetent. They information can be given when they are pain free, they can take decision for themselves. Okay. Another same it is the same thing what I have explained. If they are refusing any treatment or if they are choosing a suboptimal intervention, then you can't say that patient doesn't have a capacity. Apart from this, if information is not given in appropriate format and she's making suboptimal decision or she's refusing any treatment, then you can't say that patient has got no capacity. So this is important to understand, that if she's choosing or suboptimal treatment, if she's refusing any treatment, or if she's in a pain, You can't say that patient has no capacity. Patient can choose anything. Now, a few things about legal advice. So, like, eh, in case of women losing capacity after choosing consent to a treatment, uh, following previous discussion during pregnancy, even if at the expense of fetus, her wishes has to be respected in the same way as were she were competent. For example, what important to understand, like in the pregnancy when she was pregnant, there had been some discussion, and that time she has made some decision. Later on she lost her capacity, mental capacity. In that particular situation, whatever the decision she has made during pregnancy, her wishes has to be respected, even if that particular decision um, harm baby, or whether it is at the expense of fetus. That means whatever decision she has made, taken in antenatal period, her decision has to be respected. This thing. Second, if the patient if there is a doubt that patient, whether the patient can foresaw the present circumstances while making her choice, like any confusion is there, any doubt is there, then legal advice can be taken. Apart from this, when the patient has no capacity for medical intervention which is non-therapeutic or controversial, for example sterilization, it has to be done with the legal advice. For example, you will get a number of scenarios. Usually they will say, the mentally incompetent girl or girl with the less capacity is there, and parents have come, they are requesting for hysterectomy. So how can it be done? So answer will be legal advice, because that is a non-therapeutic or controversial treatment. Apart another situation, similar kind of situation, to avoid any fear for pregnancy, the girl living in a care home, and the caretaker comes and they say, we want to get her sterilized because of the avoiding any unplanned accidental pregnancy or anything, and they're asking for sterilization. Your answer will be legal advice. You can't do that, because that will be non-therapeutic or non-controversial treatment. For that, a legal advice has to be taken. Now this is very important for everyone, for part 2 and part 3 people, because whenever the complication occur during surgery, for trauma to viscous, that means any ureter injury, any bladder injury, any bowel injury, then that time corrective surgery can be taken, but the full explanation should be given uh, whenever it is possible after the woman's recovery. So part 2 people, you will get a scenario that you were doing surgery and some bladder injury or some injury had happened. So in that particular situation, answer would be yes, you can go ahead with the surgery in the best interest of the patient, because you can't leave patient as it is. And part 3, always the station comes. Even this exam also, the station had come when the patient has been taken for cesarean section, and there had been bleeding, and the hysterectomy has been done to arrest the bleeding. Now you have to go and meet that woman. So this kind of station do come in part 3 also. So that also requires counseling. So counseling means the explain whatever this line is writing, giving explanation as soon as practical during women's recovery. So this part of the part from this is usually done in this part 3 stations. So if any complication happens, like any trauma to viscous happens, yes, as for the sake of women's recovery best interest, clinician can do that particular surgery. Second part of it, like if if any unexpected pathology you have found, like any mass, any ovarian mass or anything had been found, so in that particular situation you can't, it will be unwise to proceed. You can't do that surgery. Why? Because consent has not been taken. And even if this patient has go to second surgery, it's fine, she will go for second surgery, but you can't do the extra treatment. So that means whatever you have discussed, whatever you have documented, only that part of the surgery you will be doing. Extra you can't do. For example, you are doing surgery for any other thing and you find patient has dermoid, you know, you can't remove that. You have to leave it as it is. So later on the patient wakes up, you will explain her, she will decide after that that surgery will be done. So this will be in second operation for her. But yes, it's fine, you can't do any additional surgical procedure. Very important, because it is important for part 2, it is real important. Part 3 also, you know, in between something a role player ask and you should know it. Are apart from this, if any if apart accepting emergency surgical procedures, any pelvic mass, gynecological or non-gynecological, if that is outside the that compliance or competence of the operator, that should not be open unless assessment for special appropriate specialist has been taken place. For example, if you find you are doing any surgery, if you are finding any gynecological and non-gynecological mass, you will not do any treatment. So the patient, like later on, she will appropriate investigation has to be arranged, or she will be assessed by appropriate specialist. After that, her surgery will be done later on. So this is very important for you guys to know that what is your limit, what can be done if it is unexpected, and where you can't do anything. Basic principle is that whatever you have explained to the patient, whatever the consent has been taken, only that much part can be done, unless it is like life saving for the woman. So any trauma, for any trauma that has been done during the surgery, corrective surgery can be possible with exploration later in post-op period. Apart from this, no, and for any other unexpected pathology, no additional surgery will be done. Also, it is very important to know unexpected pregnancy. So first of all, like all step whenever this patient is taken for surgery, any patient use every time they want to rule out pregnancy. So people will be knowing in their pre-op ward round part 3 people, in pre-op ward round, they always used to say, I need to do pregnancy test to make it sure she's not already pregnant. So it is very important, you can't take any pregnant patient for any kind of surgery. So all reasonable steps has to be taken to exclude pregnancy before the surgical procedures. Apart from this, if you find any viable pregnancy, you can't do any termination, because that is not allowed in the abortion act. So for example, today now patient has been taken, you are going and taking a patient for hysterectomy. All of a sudden, by somehow you find that patient is pregnant, you have to reschedule that operation. You can't take away this patient for any surgery. Because first she has to decide what she will do for the surgery, for her pregnancy. After pregnancy has been, pregnancy has been terminated, or she has delivered, or whatever it is done, then only later on hysterectomy can be done. So you will get a question that you did a pregnancy test comes positive and she is posted for hysterectomy today. Your answer will be rescheduling the surgery, because you can't do that. It is not possible that you can go ahead with the hysterectomy, even if even if you are even if the hysterectomy, you are taking this patient for hysterectomy, still you can't do the if you do hysterectomy in a pregnant uterus, that means you are doing termination without her wish. That is not possible. So you have to understand this. This is a very important patient safety point for part 3 people in pre-op ward round station. Second situation for part 2 people. So many times you will find, there is a scenario, and they will say that there had been a purple colored tube and it is ectopic pregnancy. Possible what to do in that particular situation? You can remove unexpected ectopic pregnancy. Like today, I have taken a patient for diagnostic laparoscopy, and I found, okay, this patient has an ectopic pregnancy. I will not close. I will do treatment for ectopic pregnancy, because I am doing this as a part of life-saving procedure. So unexpected ectopic pregnancy uh, can be removed as in the best interest of the patient, as a life-saving procedure. So this part you have to know, understand that you have to know what you can do and what you cannot do. Okay, so till here, this is the all that I had to say about the the obtaining valid consent, that clinical governance guideline number like 6. It was the complete explanation for clinical governance advice number 6. So any one of you have got any question till now can ask me before I move ahead. Any question till now? Any question till now? Okay. Now I'm
Ma'am,
moving. Okay. Yes.
hello, ma'am. Ma'am, I
Mhm.
have sent my query in chat box. I wanted to ask if the lady is in transverse line and refusing cesarean. So anyway, she is not going to deliver. So autonomy will not work. Now we should proceed in her best interest because otherwise uterus will rupture. So what we should do
Where
in
you
case
have,
of transverse line?
okay, where is your question?
Ma'am,
In
I
group
sent in chat box.
chat box. Okay, I will answer your question. Okay, I will answer your question. Because I can't
Yes,
see, I will answer your question. So now coming to now valid consent. So this you have to remember, part 3 people, basically, because it is asked in the station. In Lisa Joel's book, there is a station number 1, and there you have to explain the principle of valid consent to your junior colleague. So you have to remember it. So patient, so what are the key principle for consent to be valid? Patient should have a capacity to take informed decision. Okay, so that means patient is considered to be competent. So she has to have a competency. She should be able to understand the information, and she should be able to communicate back the decision, and it has to be provided voluntarily. Okay, in most of the cases, decision to provide or withhold the consent will be by the patient only. So it will be her choice whether she wants to go for any surgery or she wants to withhold. She can't be coerced by or influenced by carer, family, friend, member, or anything. It should be taken at appropriate time, and patient's dignity and belief has to be respected. So it isn't voluntary, it has to be done voluntary. Very important, what is the informed consent? So informed consent means that you are explaining everything to the patient. What is the procedure, what is the benefit, what is the risk, what is the alternate management strategies, implication if she doesn't go or surgery. And so written consent will be in documentary evidence only. So it like patient has to be given informed, fully informed consent. So and it can be withdrawn at any time before surgery. Like on the in the morning of the surgery, one hour before, she can withdraw consent. It is not that if she had agreed one, then she has to go for the surgery. So sometime you will get this kind of question also. Partly this kind of station also had come. Now I'll be moving to this. This is not very good talk, but it is related to capacity and consent, so I have to put it here. I'll try to cover it in a simple way. Hope that helps. So now, so does a patient has a capacity? So what the capacity means, patient should have a legal age and sound mind. Competence, she should have intelligence and understanding. No adult may consent on behalf of another adult. On rare occasion, court order is necessary. Now, what is a mental? When we say that patient has a mental capacity, whatever the information you are giving to her, she's able to understand. Second, she is able to retain the information. Whatever you're speaking, I'm able to retain in my head. Then weigh up the available information. That means what information you are giving me, I'm able to think, okay, this is good for me, this is bad for me, I should go for it, I should not go for it. So that means I can weigh the risk and benefits. After I have do the weighing of risk and benefit in my head, I can give you my decision. Okay, I would like to go ahead with it, or I would I don't want any surgery or anything that, or any treatment. So I can communicate back to the health professional or doctor. So it will be then it will be the communicating their decision back. So if a patient, so this is the mental capacity. So it is important. So patient can understand the information, patient can retain the information long enough to make decision. Patient will be able to weigh up the risk and benefit and able to communicate to you back. So if a patient can do that, then the patient have mental capacity. Apart from this mental capacity act, five things you have to know. What the five are the key principle. So first of all, uh, what the act says that for everyone you will assume that they have a capacity unless it has proven otherwise. Second, every effort should be made to support the patient making in their decision. For example, if a patient is not able to understand the language, you will call for interpreter. If the patient wants is using sign language, you will arrange that. If the patient wants any picture, not able to understand the way you are saying pictures, anything can be given. So every effort should be made to support the patient. Third thing, this I have spoken before also, patient has got her their own right to make decision, whether it is unwise also. If I'm taking wrong decision, it's my choice, it's my right. It has to be in best interest, and there should be least restrictive restriction of the human right. Like she has to make her decision herself. Her it is her human right. We will we as a there should be very least restriction to it. This is a table from that talk, explains the same thing only what I have spoken. I have just put some so what the pre-assumption of capacity. So yeah, like it is assumed that the and that everyone has a capacity. Okay, and it should be noted that act referred only to patient over 16 years of age. Why? Because we already know, and it will be coming in upcoming slides, that under when the patient is under 16, they can take decision for their treatment, but they have to show their Gaelic competency. So this mental capacity act, there are five principles. These are the five principles, and it refers to patient over 16 years of age. Okay, it will be important. Now everyone, they assume that they have like capacity. It patient should be given all possible help before they can make their own decision. If they are making unwise and eccentric, then that doesn't mean that they don't have any capacity. It's their choice. Treatment has to be in the best interest of the patient, and there should be least anything done on behalf of an capacitated individual. There should be least restriction of their basic right or their freedom. So these are the five principles that you should know. Maybe they can ask any question. Now one thing is important, mental capacity, it is not a fixed process, it is a dynamic. What does it mean? That means it keeps on changing. For example, today if I have taken I'm under the influence of any drug, or today I have taken alcohol, or I'm sedated today for anything. So today I'll be incompetent, I can't make decision. But 2 days after, when all the effect of sedation, alcohol, drugs has gone, then I will be able to make decision. So mental capacity, maybe today I don't have capacity tomorrow I will have it. So every time whenever you have to make any decision, whenever patient has to decide, you have to check their capacity all the time. Someone has put question also some any time in the group, like patient patient was incompetent. Now you have to take some decision. So the confusion is that previously she was incompetent, and answer was assess her mental capacity. That this is the explanation, that it is a dynamic process. Maybe previously when the GP or any person has seen that patient, that was she's incompetent. Maybe right now she has become competent, because maybe for some condition she was incompetent. So the take home, what is the message behind it? So whenever patient has to taken for any treatment or anything, you have to assess her capacity. Keep on changing. Capacity keep on changing. So these are the example that were given in the talk. So if patient has hypoxia, brain injury, drug related, ketoacidosis, and psychiatric condition, so maybe these are the few conditions. There could be transient impairment of the capacity, and it will resolve with the time. So whenever you have to do give any treatment to any patient, you have to assess capacity. So it is very important to know that it is a dynamic process, and capacity is likely to change. It may improve also, or it may decline also. So this line is very important, that will help in answering your question. So the onus therefore rests on the attending physician to re-evaluate the situation and determine whether there is mental capacity for particular decision is required or is required. So if in your question, in your scenario, this says that, yeah, patient has no capacity, but as a clinician, if you are treating this patient right now, you will like you have to re-evaluate the situation, and you have to recheck or see whether she has got capacity for particular decision or not. So this is very important, for your part 2 and part 3 questions. Now this is a definition of incapacity. I have taken this from very old talk, but it was good, so I put this picture. So when we say patient has incapacity, when she's unable to understand, she's unable to retain, she's unable to weigh up the information, she's unable to communicate. So this is the definition of the incapacity. You should know. Apart from this, who have capacity? Anyone over 18 years of age has capacity. Okay, anyone above 16 but under 18 years of age have capacity. They can make decision for their treatment. But if they are making if they are refusing any treatment or anything, any wrong decision they are making, it can be overridden by their parents and court. It can be overridden by their parent and court. And if the patient is less than 16 years of age, they have like if they are competent, they have to do the competency, like Gaelic competency, they have to check. If they are Gaelic competent, then they can go for a procedure. But again, if they are making unwise any other like if they are refusing treatment, or in that particular situation, their decision can be overridden by parent or court. But if any patient over 18 years of age, whether they make wise decision, unwise decision, whether they make refuse for the treatment, no one can compel them to take any treatment. No one can compel them. Okay. So like in 16 to 18 years of age, if refusal to treatment can be overridden by parent and court. Under 16, they have to show Gaelic competency has to be done. Their decision or their refusal for any treatment can be overridden by parent or court. So this you have to understand. Now sometime this will be this also you should know. If the assessment leaves in a, if there is a doubt about the capacity, So what can be done? So help can be taken from nursing staff or other people who are involved in her care, so they can be contacted. Apart from this, those people who were common close to women, they can be used. They will have an idea about her needs. Apart from this, if you are in doubt, you can take help from psychiatrist, neurologist, speech therapist, and language therapist. Apart from this, if every step you have taken still you are unsure, then legal advice can be taken with a review, asking a court to determine capacity. Legal advice can be taken. I just showed you that table, in that second column was that patient should be helped to make decision. So this way the help is done. This way the help is done. This is important that you should know this. Now, this is also important for you for part 2 and part 3, both people. So, if the patient has capacity, they can understand, they can remember. So, they can, refuse, consent to refuse take treatment. There is a two-stage test. There is two-stage test for mental capacity. It do have a two component. One is diagnostic component, another is functional component. So, what is diagnostic component? Diagnostic component is it realizes assessor to determine whether there is disturbance or impairment in the functioning of mind or brain. For example, diagnostic component will like help whether the patient can there is impairment in the function of mind or brain. For example, whether patient is alcoholic right now, or whether the patient is in the stroke, or whatever like diagnostic component will tell whether any disturbance or any impairment is there in the functioning of brain. Okay. And second stage of the test is the functional component. Functional component is the same. It will dictate whether um, patient individual will be able to unable or unable to perform one or more of these four tasks. That is, understand the information, retain the information, weigh the information, and able to take decision, and they can communicate any decision. So this is the functional component of the two stage test for the assessment of mental capacity. So it is very important. So again, I'm saying there is a diagnostic component that will that helps in finding out whether there is a disturbance or impairment of my functioning of brain is there or not. Second part of the test is the functional component. Functional component will again do the four things: understanding, retaining, weighing, and communicating the information back. So for part 2 people, directly question will come. Part 3 people should have a knowledge of this, because these kind of question do stations do come. Now, important thing is that, like, decision making models. So if the patient is incompetent in or incapacitated, then usually there are three kind of decision making models are there. It is important to understand. So one is advanced care planning model. There are three components of it. I'll be speaking about everything because it is important that you guys should have a clear idea that will really have been answering the question well. So advanced planning, that there are three components: advanced statements, advanced decision or ADRT, advanced decision to refuse treatment, and third is LPA, lasting power of attorney. Lasting power, so this is advanced care planning model. Second model is substituted judgment. Third is best interest. So I'll be speaking about all three, so that you guys will have a clear idea what uh, everything is, because it really helps in answering your questions. So in advanced care planning model, three parties there: advanced statement, ADRT, and LPA. Now I'll be speaking about everything. So what is this advanced statement? Advanced statement, they can be oral or they can be written about patient wish for their social care, for their medical treatment in future. Okay, these are not legal binding. So healthcare professional can consider these are the wishes of the patient before, if later on they lost capacity. Apart from this, these advanced statement, they don't have authority of refusal of any treatment. ADRT authority is not there. So if the decision, so that means whenever the decision making is required in the best interest of the patient, it can be done, because advanced, if the advanced statement has got no legal binding, advanced statements has no legal binding. So I'm just summarizing it again. So advanced statement can be oral and written. A patient wishes about their treatment, they are not legal binding, they have got no legal binding, and they uh, like they don't have any authority of refusal of any treatment. So these are advanced statement. Now coming to advanced directive or advanced ADRT, this is very important because it is asked in the both part 2 and part 3 viva also. So like what is advanced decision? So advanced ADRT, like this is legal binding statement for refusal for any medical treatment, including even life sustaining intervention also. So if the patient has ADRT or advanced decision for any kind of treatment, then it has to be respected. And it apart from this, it do have a legal binding. And ADRT, some basic care doesn't come, like provision of food, care of drink by mouth, or repositioning, or for to prevent bed sore. So it really clarifies which advanced decision has to be made and recorded. Apart from this, like if mm, if any treatment has to be done in the best interest of the patient, but patient has advanced directive or ADRT, then ADRT will have a value over the best interest treatment. So for example, if a patient requires, if patient has made any advanced directive or ADRT not to take blood, for example in Jehovah's Witness, now she is bleeding, in the best interest ideally the blood products has to be given. But if she has made ADRT, in that particular situation, if she dies also, you can't give her blood. So this is advanced decision to refuse treatment or ADRT. So there is a difference between advanced statement and advanced decision. Is this thing clear, or like anyone any question about that? Is it this clear? Any question?
Ma'am, doubt, ma'am.
Yes.
In
Yes.
advanced decision, you say that the patient cannot refuse treatment, even if refuse any treatment, ma'am, in advanced statement.
No, no,
The,
can't.
even if she refuses treatment, we can override that in the best interest of the patient, according to
Yes,
the
yes,
advanced state.
yes.
But ADRT, it says that the patient's capacity is the ultimate. Then how do we mark the answer, ma'am? Because two different things, two different answers for the same question.
See, advanced directive will only work if the patient is incompetent.
This is the same with advanced statement also, ma'am.
Nice. See, I'm just repeating it again, then you ask your question again. In advanced statement, they are just making any statement. It do have no legal binding. There is no legal binding. If you have to do any treatment for the best interest, you can do that treatment in advanced statement. But if she has done advanced disease ADRT or advanced decision has been done, that is legal binding. Whatever written, you have to follow that. If the patient dies also, then also you will follow that, because it is legal binded document, and it do have all powers. This is the difference. Now is it clear about your question? Because your question was now not that clear to me.
No, ma'am. In advanced statement, it might be written or oral. So even if it was in written, then how will you proceed with the case, ma'am? In advanced statement, the patient is already written when she was in capacity that you could not give blood in a case of Jehovah's Witness. Then how do you say whether it is an advanced statement or an advanced ADRT, ma'am?
It
We do not.
okay, ADRT has to be recorded, and it has to be like some, that stamping or legal thing is done there.
Okay, ma'am. Okay.
Okay. Yeah.
Okay.
So, excuse me, ma'am. So, in ADRT, it has to be recorded or it has to be a written document. In advanced statement, it may not be a written one.
It
Is it
can
so,
be
ma'am?
written, it can be verbal, but legal binding is not there. That means like no recording, no that with the lawyers we do that, that legal thing stamping. All this thing will not be done in advance statement, but it will be done in ADRT. It will be recorded, and it will,
Okay.
all the things that is required, that will be done in ADRT. So this is the difference.
Oh, okay, ma'am. Thank you.
Okay. Again, it is important to know lasting powers of attorney. It is important for both part 2 and part 3 people. So, lasting power of attorney, like it can be done if the patient, if the person or is over 18 years of age. Okay, and he will appoint a person who will take decision for her. If her decision making ability, it will reduce in future, and the person who she chooses as an attorney is called as a donee. Okay, maybe it is important for part 2. And this LPA has to be registered. It has to be registered. Like if I'm choosing any person as my lasting power of attorney, so I have to that document, I have to go and get registered that document in the office of public guardian. It has, in that office it has to be registered, then only it will become valid, and then only it is come to effect. Similar kind of thing, it is like, and lasting power of attorney, there are two types can be there. It could be related to property, like patients, like a woman's health, sorry, that property and money and everything. Or it could, another type is health and welfare. So proper property and affair, LPA has replaced enduring power of attorney, and donee of this LPA appointed to make decision. So like property and affair, LPA will make any decision that is regarding to her property or financial matter. But health and welfare, like LPA, he will be the person who will be taking decision about her health and personal welfare. So there could be two types of LPA, but as a, what is important for us it will be important only health and welfare, LPA or power of attorney. So that you have to know. Apart from this, it is not that she can choose only one person to be, donee. She can choose more person also to make different decision. Maybe one person will decide for her health, another person will be deciding for her, property or whatever the situation. And like donee of the LPA, whatever the decision they are making, it has to be in the best interest framework. Apart from this, this yellow line is important here. Like if patient, she has made advanced decision like few months before, now she has appointed LPA, then who will have a power? Then LPA will have a power over advanced decision. LPA will have a more power to make decision then what, or he LPA will be able to override the decision that is written in the advanced decision. So this part is important. Maybe in any question they will write, she has made this advanced decision. Later on, LPA has been appointed. So, whose decision will be valid? Answer will be LPA. LPA will has been given a power to make decisions. So like LPA will be making that decision. So then advanced decision will not be valid that for that woman. So because again LPA will have and more power than advanced decision. That you have to understand. Is it clear about lasting power of attorney? Though just understanding is required, too much knowledge for this is not required. Is it clear about LPA? Okay, so this what I have just spoken is the advanced decision. So what I said, there are three models. So it is the advanced decision for care model. So I have spoken about advanced statement, ADRT and LPA. What is so second? What is the second model? Second model is a substituted judgment model. So in substituted judgment model, usually decision is made by the third party. And it is considered that the decision that is made by the third party will be comparable to the uh, decision what incapacitated individual would have made. But if it is not in the best interest, then court of protection will have a power to overrule or reject this decision if it is not appear in the best interest of the patient. So this much is important. This much is enough to know about the substituted judgment model. But this model is not used. What model is used is the best interest model. So you should know about the best interest model only. So best interest model, what is the key premise of MCA is whatever the decision should be made is in the best interest of the individual. So and if of course a doctor or any health professional, if if they are not making any decision that is in the best interest of the patient, so there could be possibility of legal challenge. So basically what they are using is the best interest model. Apart from this, it is important to know IMCA, Independent Mental Capacity Advocate. So like sometime there is no relative, there is no friend, no LPA, like nothing is there, and some decision has to be taken about a patient. Then usually independent mental capacity advocates are there, so they will be taking decision. So that is the sometime it is important, it comes in the question. So if no one is there to take decision or consultation and patient has no capacity in that particular situation, independent mental capacity advocate will be helping. Apart from this, consent form, like in NHS there are 4 consent forms are there. Consent form number 1, 2, 3 and 4. Consent form number 1 is for the adult people who have got capacity. So whatever we fill, that is a consent number 1 only. But for the people who have got no capacity for any surgical procedure, consent number 4 is filled. So now this you have to know that this is a consent form number 4. So here now it is very clear. They will do the assessment of patient capacity, and if they find that patient is has got no capacity, then they will check for the advance decision for whether any ADRT is there or not. After that they will check whether any lasting power of attorney is there, or whether any LPA is there or court appointed deputy is there or not. Okay, after that they will if it is like not there, then there will be assessment of the patient best interest. So the treatment will be done in the best interest of the patient. but whatever the treatment they are doing, the best interest of the patient, they're still they're still involving the patient's family member and the other. Apart from this, if nothing is there, then at the end this independent mental capacity advocate will come. Independent mental capacity advocate will come. So this way the after the this way the consent is done, like for the, if a adult who lacks the capacity to give consent for any investigation or treatment, it is real important to know. So I'm repeating it again. So there is a consent number 4. There will be assessment of patient capacity. Then if she has no capacity, they will check advanced decision. If it is there, then it is fine, they'll go with it. If it is not there, they'll check for the LPA or court appointed deputy. Otherwise, there will be best interest. Treatment will be done in the best interest of the patient. But involvement of partner, patient's family member or others that are close to patient can be done. If nothing is there apart from this, then the independent mental capacity advocate will come. So this way the consent is filled. So it is very important that you guys should know this. So I think this I have done before. I think it is repeat again. So if any doubt is there in patient capacity, nursing staff or others who are involved in the care, they should be contacted. Anyone, those who are close to women should be contacted. You can take help from your colleagues, psychiatrist, language therapist. Apart from this, legal advice. So this is the legal advice only. This is the if they are doing an like if the advocate is taking any decision, IMCA, so it is a legal advice only. So this understanding is important. That will help you in answering your question. Is this thing clear? Is it clear? Anyone, any question? Any question? No question. Apart from this, now it is from the strategy. I wanted to cover the topic as a whole, so I put it from the strategy. So patient with the learning disability. So under English law, no one is able to give consent to examination or treatment for adult of an adult unable to give consent for him or herself. Therefore, parents, relative, member of healthcare, or anyone cannot make any consent on the behalf of other. If any necessity, then legal advice can be done. Most of the hospital, they have got legal advisor on site. Most of the trust there, they would have a legal advisor on site. Apart from this is almost the similar kind of condition. If patient has a learning disability, all care should be done with the time and support so that they can maximize their ability to make decision for themselves. So like if she has got problem in retaining information, then written copies can be given, then some videos can be given, so audio video recordings can be given. So usually if she's not able to retain too much of information, so she can go through it. So all steps should be taken. If any advanced ADRT is there. So okay, someone was asking about ADRT and statement. So if any ADRT, it has to be recorded, signed and witnessed. Statements are not recorded, only ADRTs are recorded, signed and witnessed. I think now the answer would have become clear. Someone asked this question. So key principle is that whatever the treatment is done, it has to be in the best interest. It has to be in the best interest. So first try to take all effort so that wishes of the patient, you are able to know. And if it is not there, then whatever the treatment, it has to be in the best interest. So any question till now? Any question, anyone? No question. Okay. Now, one thing is very important that you should know is the Montgomery ruling in 2015. In 2015, there had it is a very huge, there had been a lawsuit and there had been a very huge amount of money that has to be paid by NHS to this woman. What was the case actually is she had a baby, she had, and shoulder dystocia was there, and baby had some complication. So then later on she complained, I was not, she was not given like option of cesarean, otherwise she would have chosen that. So because of whole the situation, there was a big lawsuit and there was a big amount of money that has to be paid to this woman. After that, the concept of inform and what was the impact of it. Informed consent is a fundamental become the fundamental principle of healthcare. Anyone receiving medical treatment must agree to go under that treatment. So like this is lining from there only. Now this is the same thing. Now previously it was a Boehm's test. Like if the patient if the patient doctor has done something, and if doctor is not found any guilty of negligence according to the practice, so it's fine. But after this Boehm ruling, after this Montgomery ruling, this Boehm test or Boehm thing has been now it becomes an old story. Right now what concept has changed, and now the informed decision or has come according to that. A doctor will explain everything. She should patient should be able to understand the seriousness of condition. She should be explained about the benefit, about the risk, about the responsible alternate. So all now it has become informed decision, and in informed decision everything has to be explained to this patient. Everything has to be explained to this patient. So right now it is not only just signing on the consent. So everything has to be explained to this patient. So that's all about the Montgomery ruling that you guys has to know. It comes in your question also. Apart from this, this is again from strategy. So what is medical negligence? Definition: if there is a breach of legal duty to take care that has result in the damage. So if there is a breach in the legal duty of a doctor that result damage to the patient, so that would be medical negligence. So previously Boehm principle was there. So if I have done something that is not according to the practice of my hospital, but it is this practice is done elsewhere in the world. So that was a Boehm principle. So medical professional was not used to be found guilty. But now this has been gone away. Now now after Montgomery it has been informed decision that apart from this, like patient should be aware of any material risk. Patient should be aware of any material risk. So that part is important. Now what is, so it is explanation of everything to the patient, all options, all risk, benefit, alternate, even the possibility what can happen if she's not opting the if she's not opting the treatment. So now this has completely changed after Montgomery ruling. In previous old question, you will find something about Boehm's test, but that has become an old thing now. Now it is not there. So now it is the according after the Montgomery case, like it is a duty of a doctor that patient should be aware of any material risk. Patient should be aware of any material risk. So what is the material risk? Whether the a risk is material when a patient requests the information or not, or material risk to which doctor can attach some significance. Okay, it is significant, and doctor has some evidence to support it, or patient would be able to attach any significance. So some significance is there. That risk is the material risk. That is the understanding from this. So I directly put the line from the strategy. So you should know, what is the material risk. This is only my understanding about it, that some significance can be attached either by the doctor or by the patient. So this is from the strategy, and this same thing. So, we need to avoid bias. We should not be like in this situation. If we say this, patient will not consider this treatment or that treatment. No, we have to avoid bias. Consider comorbidities. Describe the risk. Describe the risk. Whatever is the risk. Frequent risk, serious risk, blood transfusion, or any unplanned procedure. So it is a everything has to be explained to the patient. So this is the concept of material risk. Apart from this, sometimes there could be disagreement between the healthcare professional and the patient. So there could be possibility in that particular situation. What you will do, either you will consult a most experienced colleague, or you will take legal advice. You will consult a more experienced colleague, or you will take a legal advice. So this much, from that talk of 2018 that I had to say. Any one of you have got question can ask me before I move, to this talk. Though I have got very little to say in this talk. Any question till now? Any question, anyone? No question. Okay. So a few things that I have to take from said from this talk, though most of the things have already been explained. So like in emergency, if the consent, same thing we have done it before, but I have to put from this talk on also. So whatever, when the consent cannot be, in case of emergency, when the consent is not obtained, then the medical treatment has to be in patient best interest. That we already know, everything is in the best interest. Second thing, again same, if the advance directive is there or ADRT is there, then that treatment can't be given. And if patient has made any advanced decision, lasting power of attorney, court appointed deputy, so if it is practicable, then they can be contacted. Apart from this if it is too much emergency situation, treatment can be done with a verbal consent only. For example, if you see your cord prolapse guideline, in cord prolapse guideline, if CTG shows some changes and there is an emergency, they're shifting the patient for category 1 cesarean section, it can be done with the verbal consent. So in case of emergency, when the GMC says it can be done with a verbal consent. Now who can take consent? This is important for the part 3 station. So the person who is trained to do consent can take only consent. Second, person should have an adequate knowledge about the procedure, and the clinician should have an update information. For example, if I'm going to do cesarean section, so basically I have a knowledge for do cesarean section, so I'll be taking consent. Maybe any my younger junior colleague who has not done cesarean section, so he or she will not have an efficient knowledge, so they can't take consent. So who can consent? Anyone who is suitably trained or has got sufficient knowledge about that procedure that is updated. Only those people they can take consent. Apart from this, again, consent is it doesn't expire. It is continuously reviewing process. So like there is no like if I have taken consent for 1 month before or 2 months before, so it will expire. No, it doesn't expire. So it has to be continuously reviewed. That means if I have taken consent from a patient 2 months before, and tomorrow she is coming for the surgery, so before taking her to for the surgery, so again there will be review. So again there will be review of the consent. So it doesn't expire, but it has to be reviewed regularly. Maybe consent has been taken 2 months before, now some new treatment has come up, so it's a duty of a clinician to tell everything what is there, so it doesn't expire. Apart from this, few things that different I have to say, not from that talk. So in a law, 18th birthday draws a line between childhood and adulthood. So 18th it's like a person who is 18 years old, they have got autonomy, they can enjoy their autonomy as any adult. 16 and 17 years old, they can take their decision independently of their parents. Younger child, they have to show their competence. So age is clearly unreliable predictor for competency. So this you have to know. Gallic competency. So under 16 years of age, like their competency can be checked. So if that means they will give some information would be given to them, then they will be they'll be able to retain that information. They will weigh the risk and benefit, and they can communicate their decision back. So that if they are able to do that, so that is called as a Gallic test or Gallic. So Gallic competency has to be checked. And if the person is, if the child is not considered to be a Gaelic competent, then a person with a parental responsibility, a person with the parental responsibility would be required uh, to give consent to the treatment. Sometimes court involvement is also done. So this much knowledge about Gaelic competency is required. Apart from this, this I have told. But if these younger children less than 18, they are refusing any treatment, can be overridden by a parent with a parental responsibility or court. Very important that you guys have to know is what is the Fraser guideline. Fraser guideline specifically relate to contraception and sexual health. What are these Fraser guideline? So there are five components of it. So if contraception can be given if she she has a maturity or intelligence to understand the implication of treatment. She can't be persuaded to tell her treatment or allow doctor to tell them. So like it is their choice. They can be given contraceptives. They can't be persuaded or forced to tell to their parents. And it appears like they will continue having sexual intercourse without with or without contraceptive treatment. Apart from this, their physical or mental health is like to be suffered if the treatment is not given. Apart from this, the treatment is in the young person's best interest. So these are the Fraser guidelines. But still, healthcare professional will encourage the young person to inform their parents or get information permission to do so on their behalf. If the permission is not given, still the treatment can advice and treatment can be given. So if under 16 they are Fraser according to the Fraser guidelines, if they're coming for contraception can be given if they are competent. They are usually encouraged to inform their parents, but if they don't want it, then also the treatment will be given. But as a clinician, you will always encourage them to involve their parents. So there had been an SBA EMQ many times. So answer will be to encourage to inform parents. Usually this is the answer. But yes, you have to know the Fraser guideline complete, because there is a station also in the in the part 3 there are 2 stations for Fraser guideline. So it is important that you should know this. Sometime if they find that child is getting exploited or some abuse is going on, that time on even the for the safety, confidentiality can be broken. So this is all about Fraser guideline. Anyone of you have got any question about it? Any question?
So, ma'am, what I understood, under 16, you need GLIC competence, and
That is
16
for
to
medical
18,
Gaelic
yeah,
competency for medical treatment.
yeah,
Fraser
yeah, yeah,
guideline is for
for
contraception.
contraception. Yeah, yeah,
Yes.
I understand. So, but from 16 to 18, for medical this thing, we don't need any competency or anything. If they refuse, the parents has the right. This is
Yes,
what I understand.
yes.
No need to check their mental, they're competent or not competent, they understood the risk or not, from 16 to 18.
From 16 to 18, you know what the Mental Capacity Act says, that everyone they to be competent unless it is proven otherwise. So everyone they are thinking competent unless it is proven otherwise. So they
All right.
but less than 16 years of age, they have to check their competence has to be checked.
All right, doctor. Thank you.
Okay, and above 18, if anyone makes any decision, it has to be respected. They have autonomy. 16 to 18, under 16 to 18, if they are making any decision or if they are refusing treatment, then it can be overridden by parent with parental responsibility or by court. Is it clear? Is it clear? Okay. Now this also you guys have to know. So there are 4 principles for ethics, and many questions come from here. So first is autonomy. So that means whatever the patient making decision, so it is their autonomy. We have to respect their autonomy. Beneficence. Second is beneficence principle. That means we as a clinicians we do have whatever the treatment we do, it should be it provide benefit. So we have to balance the benefits against risk. So that is beneficence. Second is non-maleficence. That means obligation to avoid causing harm. So we'll not do any treatment that will harm our patients. So that is a non-maleficence. Last is justice. So like there has to have a fairness in the distribution of there is an obligation of fairness in distribution of the benefits and risk. So whatever we are giving, we'll give them complete advice. So we have we have to be fair in the distribution of risk and benefit. It is not that I'll be telling benefit more or I'll be telling risk more. No, I'm doing my duty. I'll be telling everything because I have to be fair in the distribution of benefit and risk. So these are the 4 principles of ethics that you should know, and because many times the question will come directly from there. Now this is the consent process. This is though just a picture I have taken from the website, and it is very important. So like this is the model consent process. So a patient we have to find out patient idea, concern and expectation. Then we have to explain all options including no treatment. We have to supply the information, success rate, risk, benefit, and click everything. Then we have to check her understanding. So whenever we are doing consent station for part 3, we always check the understanding of patient. Then we'll do the documentation. After that, consent filling is done, and later on when everything is done, then only the treatment is done. So this is the model consent process that will everything, but just an reinforcement of what we what is the consent. So this part you have to know. Apart from this, now these are the consent advices. Number to remember. It is it is very difficult to remember, but so many questions they come. Part 2 people, they have to remember this number thoroughly. Part 3 people also has to remember, because in some consent station role player will directly ask you numbers. Some numbers are important, like for this consent. This is the new consent that came in 2018, surgical management for removal of pregnancy remains or fetal remains. These numbers are important. Everyone, part 2, part 3 people have to remember these numbers. So usually the risks are frequent and serious. So what is the frequent risk? Is the bleeding. So apart from this need for separate repeat procedure, and pelvic infection, number is same, 14,1,000. Development of intrauterine adhesions, it is 119, 1,000. So all 3 are in 1,000, that you have to know. And bleeding is 1 in 3 in 1,000. Heavy bleeding is 1 in 3 in 1,000. So these are the frequent risk. We already know that the patient come to us with a bleeding only. Most commonly what the patients are coming with the bleeding. So it is 1 in 3. Heavy bleeding is 1 in 3 in 1,000. Repeat procedure and infection, these are the same, good, same number, 14 1000. Adhesion is 119 1000. So everything is in 1000. That is important, very good thing here. This, from this you will get a number of questions. This is the famous line for question. Perforation 1 in 1000, and like cervical tear at the cervix, neck of womb is cervix. So cervical tear, it has to be very less. How much cervical injury, it happened when we do this, like when we are doing evacuation, it is 0.1 in 1000. So it is uterus perforation 1 in 1000, cervical tear, it is 0.1. Okay, 0.1 in 1000. This number, everyone, part 2 and part 3 people have to be done, because in consent station you have to speak about this number. Now diagnostic laparoscopy is very important consent, and everyone, part 2 and part 3 people has to know it, because the viable station do come from diagnostic laparoscopy, role player station comes from diagnostic laparoscopy. You have to know this very well, and this is the number from where the question comes. Serious complication in diagnostic laparoscopy 2 in 1000. Number has to be by heart for everyone. Then 15% of bowel injuries are missed. This is already a station in the part 3, bowel injury, so you have to know 15%. This number has to be remembered. Apart from this, hernia is 1%. Hernia is 1% that you have to know. Death is 3 to 8 in 1 lakh. These all the numbers are very important for the question. Frequent risk, very good, they have not given any number, but still it is important for part 3, because they have to counsel their role player. So these is all numbers you have to mug up for part 2 and part 3 people. Consent laparoscopy is real important. So this is hysteroscopy. Hysteroscopy consent, or hysteroscopy also are station in part 3, and a role player will ask you question. Role player will ask you question, and yes, it is again 2 in 1000. It is 2 in 1000. Okay, so overall risk of serious complication is 2 in 1000, and like death is 3 to 8 in 1 lakh. This serious risk and frequent risk important for part 3 people for the hysteroscopy station. Now sterilization, again a very important, every one of you have to remember this number. So what is the risk of failure? 2 to 5 in 1000. But if you see sterilization guideline, there the number written is 1 in 200. But if you see 5 in 1000, it will come 1 in 200 only. So it is the almost same number. There it is 1 in 200, and here it is 2 to 5 in 1000. With the calculation, it will come the same number. So you have to remember this number. Apart from this, blood vessel injury 2 in 1000, and laparotomy 3 in 1000. Important number you have to remember. And death is 1 in 12,000. It is also important. Male sterilization failure 1 in 2000. This number is very, all the numbers are important from here. Now cesarean section again is very important, because from cesarean section also, it keeps on coming, question keeps on coming. So like serious risk and frequent risk, I have made 2 paper slides. Now the serious risk, what is important to know, that thromboembolism is 14 to 16 10,000. This number is important. Bladder 1 in 1000, ureter 3 in 10,000, because we already know when we do cesarean section, bladder is too much near when we when we cut the UV fold, put it down. So 1 in 1000 there could be injury, but ureter, it is far away. Whenever any broad ligament thing, hematoma had happened or something, then ureter will like to injure, get injury. Okay, if there is that had happened in hematoma, usually this is 3 in 10,000. So this number is very important. This number is very important. Apart from this, these are the few other numbers, but basically these 3 numbers from where the usually the question comes. So embolism 4 in 16 in 10,000, bladder 1 in 1000, ureter injury 3 in 10,000. These are the serious risk of cesarean. Frequent risk of cesarean, it is very important that you have to remember is the fetal laceration. Usually 1 to 2 in 100, 1 to 2 in 100. From here the question comes. Now repeat cesarean section is 25%. So if sometime the question come which is the most common from the in the cesarean risk, so your answer will come increased risk of repeat cesarean section, because it is 25%. Now you can see all other risk what we are seeing 9%, 1 to 2%, 0.5%, 6%. So here also whatever the risk, they are in thousands or 10,000. But here if you come to frequent, it is a repeat cesarean section, that is a maximum, that is a higher, that is a highest. So it is sometime question come from here. So this number 25% we already know, so this is the highest risk for the cesarean section. Now cesarean section for when there had for placenta previa, there are a number of questions come from here. So all three number I have put in red color. Risk of emergency hysterectomy 11%. Another, but the question also come from this line. If in your question they write placenta previa and previous cesarean section, hysterectomy is 27%. 27%. So now you have, please don't make mistake here. If you are doing cesarean for placenta previa, only placenta previa, hysterectomy is 11%. But if placenta previa and previous cesarean section, risk of hysterectomy is 27%. Usually people make mistake here. These are the two numbers that you have to remember. Apart from this, another question what comes here is what is the major problem? Major problem is it is the MOH. How much is a percentage for massive hemorrhage? It is 21%. It is 21%. And future placenta previa, it is 23%. It is 23%. But usually what the question comes, emergency hysterectomy with placenta previa 11%, emergency hysterectomy placenta previa with previous cesarean section is 27%, MOH is 21%, MOH is 21%. So these are the few numbers, though from there usually the question comes. Very bad, but I can't help it. Now coming to abdominal hysterectomy, this is important. So what are the important thing? I have just put serious, from red line the question comes. What is a serious risk? Serious complication in abdominal hysterectomy? 4%. This is the common number from where the question come. And what is the maximum risk? This also comes as a question. Hemorrhage is the maximum. Hemorrhage requiring blood transfusion is the maximum 23 in 1000. This so this number is serious complication is 4%. Leaving it, if you consider this risk, all this risk, then maximum is the hemorrhage requiring blood transfusion, that is 23 in 1000. Now if you are doing hysterectomy, so what is the most common problem you have? You're not injuring bladder, bowel or ureter. Your patient is, have sometime abscess can be there, embolism can be there sometime, but maximum what you do, you just ask your anesthetist, okay, please ask and go and arrange we need blood for this patient, there had been enough bleeding. Just I'm telling, we are doing this just to remember it. So if what is the important for abdominal hysterectomy? What is the maximum risk? That is the hemorrhage requiring bleeding requiring BT, blood transfusion, 23 in 1000. So remember this. Now another question comes from here. What is the how many people death can be there? So it could be 23 in 1000. 23 in 1000. And what could be the reason? PE and cardiac causes. So this, I have tried to put in the numbers this way. Abscess, VTE, return to theater, and injury to bladder. So this is 2477. So abscess is 2, VTE is 4, and in return to theater and bladder are equal 7, 7 in 1000. Try to put this in this way so that you can remember. Apart from this, these are the frequent risk, but you have to remember ovarian failure is also there. So ovarian, sometime you will find question. So ovarian failure is a frequent risk. Frequent risk. Why it is frequent? Because when you are doing self TAS, that time you are putting a clamp, and usually the blood supply to ovary is it is hampered. Therefore, the ovarian failure is frequent risk in AH. Now VH also, what is the important question comes: excessive bleeding requiring blood transfusion, return to theater, that is 2 in 10,000. So whenever we are doing vaginal hysterectomy, we always arrange blood usually, because it is very common, because when we are separating the planes, there is a bleeding. So 2 in 10, 2% is the risk of BT. Here it is in abdominal, it is like again it is almost same. It will come 2.3 only. So maximum risk in AH and maximum risk in VH, it is the bleeding requiring blood transfusion. Bleeding requiring blood transfusion. Again, you can just remember this. I try to put it here: bladder, abscess and bowel, BAB 235 in 1000. If like the weight, so that number can be revised. The way number can be revised. Now that's all I had to say about the consent and ethics. Now I have got lots of question. Till now, if any one of you have got any question, can ask me. Otherwise, you guys can open your mic and keep answering question, because I have collected many questions from all sources. Okay, so whatever we have learned, applying them in a question would be very good, because from all possible sources, all questions are there. Now these are the cesarean section. Now this is a question: is cesarean section is needed because of pathological CTG? Patient has schizophrenia with bipolar disorder, poor mental capacity, now refusing cesarean. What could be the what will be the answer? Someone has to answer.
Do for the best interest.
Very good. So the answer is F. You have to do for the best interest. Now the pregnant woman at term, transfers lie in labor. Patient can't understand English. Cousin can do the interpretation. And he said that patient is refusing cesarean section. What you will do? Sorry. Now, what could be answer from here?
Consent is not fulfilled.
Yes, consent, because she can't understand English, and nothing can be done on her cousin's interpretation. So what is the criteria for consent is not fulfilled. So this will be the answer. Yes.
Ma'am, had she's understanding very well, then transverse lie is not going to deliver. So we should not do autonomy here, na? Because it will land up in rupture of uterus. So transverse lie can't be left if she is refusing cesarean for transverse lie, but still we have to do cesarean.
No, no.
Means
If
I'm not talking of this question. Had she is sound in mental condition and all, then what should be
okay,
the answer?
that see your that question, some similar kind of question is coming in the next upcoming slides. But patients, for example, patient has a transverse lie, she has a capacity, and she is refusing cesarean section. Answer will be respect her wish. You can't do cesarean section, whether she dies, whether baby dies, whether uterus rupture, whatever happens. Got it?
Okay, ma'am.
Yeah. So one question will come with this, similar question will come. 21-year-old
Okay.
refusing cut in abdomen in spite of CTG pathological. Similar kind of question it is, what you are saying. What will be the
Respected.
answer? Yes.
Respect her decision.
Yes, respect her decision. So pathological CTG baby is going to die, but she's refusing. So she has capacity. You so respect her decision.
Baby, she is not worried about baby, but in transverse line, her uterus will rupture. So, as in case of rupture ectopic, we proceed in best interest. So,
Mm-hmm.
I'm asking why not best interest in transverse line? Because in rupture ectopic, we proceed for laparotomy.
Yeah, so you are doing when you are suddenly finding out a patient is open in theater and you find ectopic, then you are removing it in the best interest. Here, patient has capacity, patient is awake. You can't do. Have I
Okay,
answered
ma'am.
your question?
Yes, ma'am.
Yes,
Yes,
you
ma'am.
can't do. You can't do. Whatever she says, you can't do.
Okay, ma'am.
You see 15-year-old girl in family planning clinic. She lives with her parents. She doesn't want to tell her parents that she is 8 weeks pregnant, which is unplanned and unwanted. What should be the answer?
Refer for
Give
termination.
no pregnancy.
Yes, refer for termination of pregnancy is the answer. Now, 14 years old girl who is sexually active doesn't want parents to know about contraception. On examination, you notice bruises or rashes, but you are not sure what are they, what you will do.
Refer to medical medicine clinic.
Involve pediatrician. She's 14 years old. She's right now with you. She will not go to gum clinic. She will.
Inform the police.
Why you are informing the police? First, you
Inform
have to see
social
this patient. See, first you have to see this patient clinically. You have to involve pediatrician. After the diagnosis is made, then only you will inform. Maybe she fell down. Maybe there is no sexual abuse. All of a sudden, why police, social service, or anything will come? First, as a doctor, you see it. Involve pediatrician. When you are able to diagnose anything related to abuse or anything, then social service will come. Have I answered this question?
Yes, ma'am.
Yes. Maybe she's having rash with no reason, with no abuse or anything. So first I have to make diagnosis. So I'll be involving pediatrician. This everybody knows now. What is the uncommon?
1 in 100 to 1 in 1,000.
1,000.
Yeah, this is a simple question. Everybody knows. Okay. Now, like 23 years old Jehovah Witness, her presenter previous cesarean section. So she has presenter previous 36 weeks of gestation, planned cesarean section. She refuses all blood product. In her antenatal clinic, the form has been signed and healthcare professional understand her wishes. So what is this?
Advance directive.
Yes, advanced directive, advanced decision is the answer. Advanced decision.
But it is written, na?
Yes, advanced directive is always written, documented, witnessed, signed, everything. Okay, 82 years old woman who is diagnosed with stage 4 endometrial CA, and she's able to she decide that her son will make decision on her behalf if her healthcare deteriorates, so she lacks capacity. So what is this?
Lasting power of attorney.
Lasting power of attorney.
Yes, very good. This is lasting power of attorney. 72 years old with stage 3 ovarian CA, treatment is palliative. She admitted to medical ward following stroke, but medical team now ready to discharge. Medical team has asked you to review and make a care plan for her discharge. However, patient is unable to communicate with regards to her wishes for the her wishes for rest of the treatment. The patient can't do anything. So what you will do? And they are discharging this patient.
Can it be
Consent.
H? Consent relevant persons to determine
Yes.
a court of
Whatever you
protection.
no court of protection. First, you will consult relevant relevant person. First, you have to do best of interest. Now, this is again 48 years old for TH BSO, BMI 33, abdominal surgery type 1. Unexpectedly, you find a large mass that appears to be arising from right ovary.
C.
Yes, leave the mass alone because you have consented for ovary removal, not for mass removal. Leave the mass alone, abandon the procedure, discuss when she is wake up, refer to specialist opinion. 23 years old, undergoing for diagnostic laparoscopy for chronic pelvic pain. She had one
Can we
cesarean.
take biopsy in previous question?
No, you can't do anything. No, nothing.
Okay.
On the other side, so according to the UK, you can't do anything. And according to any other any other place also, if you take biopsy and if it comes out to be malignant, you are spreading that malignancy ovarian. So better to be safe. That is not from exam point of view, that is just general knowledge I'm speaking about. 23
Okay.
years old woman for diagnostic laparoscopy, BMI 28, irritable bowel syndrome. She's using copper coil for contraception. Unexpectedly, there is a mass in left tube, bluish tinge, appears to be rupturing the.
Salpingectomy.
Yes,
F.
so it is life-saving procedure. You are going for diagnostic laparoscopy, you can do this surgery. So this I have already spoken about. Unexpected pregnancy. 15 years old girl comes with stepmother who has not adopted her. With her stepmother who has not adopted her. Her father is only recently remarried, cannot come for appointment. Patient is due for laparoscopic cystectomy. Consultant deemed that patient has capacity. With the risk benefit alternate to explaining to her. Her parents on a previous clinic, both of father and stepmother support the patient decision to proceed for surgery. What will be the most appropriate means of completing consent?
It requires only the patient's signature.
Yes.
2.
Because previously they have proven that that she has capacity, so she's Galix competent, she can sign consent and surgery can be done. 14-year-old girl lives in a care home. She requesting contraception. She is on the sexual history, her partner is 19 years old. She doesn't feel that they are doing anything wrong. She doesn't she asked you to not share information to safeguarding team because she's afraid that her partner will be in trouble. What you will do?
Issue a contraceptive and involve the safeguarding team.
Yes, so here this girl is at a risk of abuse, so there will be breach in confidentiality. So you will give contraceptive and involve safeguarding team. 38 years old lawyer, she developed preeclampsia and controlled on antihypertensive. Most recent show, she has IUGR baby, umbilical artery Doppler, raised umbilical artery Doppler. She has capacity and she is declining for steroid and cesarean section. She believes that everything will be fine. She want to avoid surgery. What will be the most appropriate option if you are in
Respect
consultant?
the women's.
4.
Yes, you will.
Involve
If she does.
another concept.
Ensure regular follow-up.
Yes. So respect her wish and ensure follow up, because if she doesn't want, you can't do anything. So you have to respect her wish and keep on treating your patient. Mrs. A suffer from dementia. She develops pneumonia which worsens to the extent she requires ventilation. her respiratory function deteriorates during ventilation. Decision has to be made. Who will take the decision whether the ventilation should continue or not?
First option.
Read the
Lasting
question
power of attorney 4.
Lasting power.
4. Her son who has the lasting power of attorney.
Person
Best
who has a
interest.
see. Okay, her son who has a lasting power of attorney.
Consultant.
Best
The answer
interest.
is best interest
Advanced
principle.
directive.
Actually, A, if she has to refuse mechanical ventilation, that has to be mentioned specifically.
Yeah,
I'm
but
not
in
sure about one.
advancce directive, there is
That's
no
not
mention.
specifically mentioned about mechanical ventilation. So I feel it should be A for her son because he has a lasting power of attorney.
But lasting power of attorney. See, I'll just explain you. Lasting power of attorney. If she has given that right, then only he can take that decision. So they are not. They have not specifically told that what right her son has got. So answer in that particular situation becomes best interest. If they have, like in advanced directive, they are saying that what it has lasting, what type of power of attorney he has got physical, like for
Health
her
or
health,
finance. Okay.
for her finances. There is no specification, so answer becomes best interest. Got it?
But ma'am, what will the consultant decide now? That her function is deteriorating despite ventilation, and further decision regarding continuation of ventilation, what will the consultant decide? Continuing ventilation?
So that will be when the what that will be, consultant will see overall scenario, then he will decide. But whatever he does has to be in the best interest of the patient. Yes, he will, in my
Okay.
opinion, he will continue with the ventilation. This is my opinion, okay? But it will be the
Okay.
treating person who will decide. Okay. Now the patient is HIV positive. She is refusing for any treatment. She is advised to deliver by cesarean section. But she refuses to deliver by cesarean, and she wants to get delivered vaginally. She advised to avoid breastfeeding. That is recommended once the baby is born. Looking into her area, what will be the legal course of action to prevent risk of transmission to baby? What you will do? She's not happy with anything. What you will do?
Arrange an emergency protection order once the baby is found.
Very good.
Yeah.
So if baby, till the baby is inside, baby has got no right. But once the baby is out, baby has got all rights. So you can do whatever for the baby. So you will arrange an order so that baby can be treated without any delay. Okay. Now 22-year-old. Okay, so here the 22-year-old parents have come and they requesting for sterilization. So how would you manage this case? What you will do? Answer is very clear.
Court for judgment.
Yes, this is unauthorized treatment. So whatever it is done, it has to be with the legal advice. 15-year-old girl is pregnant with a 19-year-old boyfriend. Parents are not aware. Whom you will inform about her relationship?
To the police.
Why you are calling police? Any crime they have not done any crime.
It's an abuse, no ma'am.
Not abuse. 4 year difference is there only.
See, 4-year difference, that will give you an suspicion. But it is every relationship with 4-year difference is not abuse.
You can encourage her to inform her parents. Less than 15.
That is fine, but that is not there in the
Question.
option.
Social service?
The GP.
Social service. Social service, they will find out everything. They will do help. Okay. So it will be social service. 14-year-old girl accompanied by parents, diagnosis of rupture ectopic. She is having tachycardia, hypotension, and she is in shock. Before losing consciousness, she refuses to go to theater. What she will do?
The clinician can overrule this decision in a life-threatening scenario.
Yes. So clinician can overrule this decision in life-threatening scenario, and this is from the GMC guideline. 37 years old woman with endometriosis. Gynecologist at the time of surgery notices small bowel perforation. Call surgeon for assistance. So what will be the right choice? Important consideration. What they should do?
2.
Surgery to repair the bowel head.
Yes. So if a trauma to viscous has happened during surgery, it is life-threatening. Repair can be done in the decision can be done by the clinician. 45-year-old for hysterectomy. Pregnancy test has not been carried out. Now, during surgery, you find right fallopian tube suggestive of unruptured ectopic. Catheter shows UPD positive. What you will do? Contact a colleague, patient partner, continue hysterectomy with the removal of tube, remove the tube.
Actually, stop the surgery and reschedule, but not sure if this will rupture. Now, as of now, it's unruptured.
Yes, so you will continue with the hysterectomy and you will remove the tube as a life-saving procedure. This is life-saving. Okay, this I have already spoken. So what type of consent is required to do CV by the medical student under anesthesia?
Written consent.
Yeah, it is very clear, common. So 12-year-old girl with abdominal pain, hematocolpos, surgical management with a hematotomy and drainage is recommended with a clear explanation. Young girl is declining because she is scared of operation. But later on, she agreed when mother and stepfather calmed her. What will be the most appropriate action?
From the mother alone.
From the patient and mother.
From the patient, if she agrees, it's okay.
Like from the patient and mother, because she got scared, she refused it.
But she agreed after that.
Yeah, she agreed after that also, but mother has to be involved because whatever. So she was like not in a very sound mind.
Patient
So
alone, A option.
no, it will be patient and mother. Her stepfather has got no legal right, so it will be a patient because she agreed first, but she refused. So it can be overruled by her mother because mother has got a parental responsibility. So it will be mother and patient. Okay, this is from strategy. So if young girl refuses treatment, parents still can consent. Gaelic competent minor refusing treatment, parent overrule. So this second line we are doing. Okay, second line we are doing. If there is disagreement between minor and the parent, court ruling may be allowed. Okay, and if parent are refusing life-saving treatment, then then the treatment can be done for the best interest of the patient, even if later on in hospital they do some like they charge for battery, even for the life threatening, if the life threatening emergency situation is there, young girl, if she's at a risk, so life-saving treatment, it can be done. And if it is not too much of emergency, then second opinion can be taken. Second opinion can be taken. Okay. People who have parental authority can consent for the treatment. But if two parents they disagree for the treatment, court involvement may be needed. So if so mother will be automatically a person of the parental responsibility. But if the father is unmarried, then he has to apply to court for parental rights. He has to apply the court for parental right. Another situation, if there has been a divorce, then parents father right will still be there on the baby. Parents right will still be there. Okay, because in UK not usually they are in relationship, so these are partner. So mother who is giving birth, she'll be the parent with the parental responsibility automatically. If they are married, then father will be a second parent with parental responsibility. But if they are unmarried, then they have to apply it for the court to get rights. Okay, so these are the few things that you should know. 15-year-old girl accompanied by a friend with a cramps, bleeding. She has LMP 7 weeks ago, UPT positive. Ultrasound shows missed miscarriage. After discussing, she opted for surgical miscarriage. Request to keep it confidential as the parents are not aware. So what you will do?
You can proceed with the consent. Mother's consent is not necessary.
Yes, you can proceed. Mother's consent not necessary. 30-year-old has Nali Pera had a complicated forceps delivery with a for abnormal CTG. Baby born in poor condition. Baby has got cerebral. Baby is 5 years old. Baby has cerebral palsy. Till what age baby can claim baby till what age can baby bring a claim attributing of cerebral palsy to the suboptimal intrapartum care for medical negligence? What is the
No,
limit?
no age limit.
No age limit.
Yes. So according to the law, if any incident had happened, so complaint can be registered within 3 years from the date of incident. From the 3 years from the date of incident. And if a child, if incident had happened and the person was a child, so this period will be 3 years from their 18th birthday. But for patients with no capacity, there is no limit. Patient with the capacity, there is no limit.
Ma'am, in UK, 12 years is the age of minor.
Yeah, 12-year-old minor only.
And at which age they can give consent for surgery, and at any age if they are gilly competence, means even 13, 14, 15, any age they
Yeah,
can consent for surgery if they are competent.
yes, they can. If they are really competent, they it is it is on their level of their competency. 39-year-old woman with 2 deliveries present in spontaneous labor. She had gestational hypertension at 35 weeks, stable blood pressure, CTG at 8. She's in a labor. CTG becomes with a 8 centimeter dilatation, 7.9, 7.1 fetal blood sampling. She declined cesarean section. She doesn't want any operation because she has got previous normal delivery and healthy baby. She understands the risk and benefit, clearly documented. What will be the your consultant in charge? What will be the most appropriate management?
Respect her wishes and review appropriately.
Yes, because she has got capacity. So she can make any decision. Someone asking about transverse lie, now you can get an answer. If she has got capacity, Whatever happens, she can decide, you have to respect. In UK law, fetus has got no legal status. Fetus has got no legal right. Now, one of your colleague has tweeted about, after a long exhausting day, about complex case. He believes he handed over inappropriately mismanaged initially to another colleague. He has anonymized the case details and described the symptom. Atypical presentation leading to complex mismanagement of and the current complication that making it complex. What is the statement will be correct with the maintenance of confidentiality?
It is a
Second
breach.
option, acceptable to share your views about colleague clinical competence in
It is
closed group.
it is a breach of confidentiality.
He has tweeted it is a breach of confidentiality on the part of patient. You can't do
But he has
anything.
anonymized, no? He hasn't shared the detailed name and all.
But he can't tweet anything. He can't tweet about a patient.
Okay, ma'am.
This is about from the GMC. One must be very careful not to share identifiable information. One must not publicly should use publicly accessible social media to discuss patient related problems. So what he has done, patient details are anonymized, but he is discussing on public social media. Got it? Someone was saying anonymization.
Yes,
Okay,
ma'am.
this
Yes,
is
ma'am.
from the GMC website I have put. So 30 years old, para 5, 36 weeks of gestation, brought in ambulance with the pain. Pulse is 120, blood pressure 100/60, temperature 37. Placenta was anterior on examination, abdomen tender, CTG recording abnormal. She doesn't understand English. Her sister can speak English. Immediate resuscitation was done. Decision for emergency cesarean section was made. So what is the most appropriate statement in this situation with regards to consent from this non-English speaker? What should be the answer?
Acceptable to use hospital employee as interpreter. Fourth option.
No,
You can
be
can proceed
professional.
with, you can proceed with the emergency cesarean section because it's an abruption.
Yes, it is emergency. So if no interpreter is there, you have to use professional interpreter. Okay, if not there, then best interest. Okay, so because a professional interpreter should be available when possible, use of hospital employee is not acceptable. 12-year-old girl requests contraception. Her periods are irregular. Last period is 6 weeks ago. She has been sexually active for last 4 months. What is the answer?
Do the pregnancy test and then prescribe uh, contraception.
Yes, do the pregnancy test.
I.
15-year-old girl in family planning clinic is requesting termination of pregnancy. Her periods are irregular. Scan shows pregnancy. As consultation, she tells she doesn't want to tell her parents. Answer.
Proceed with
A.
surgical termination.
Medical termination.
A. Medical termination.
15-year-old girl, what you have to do? Read the options. What you have to assess?
Assess Gillick competence.
Laser, yes.
J.
25 years old with the bleeding. On examination, hemodynamically unstable. On examination, superficial vaginal trauma and tear in the posterior fourchette. requesting no intervention. There's a bruise on inner thigh. What you will do?
Inform the police.
E option, take a detailed history and then inform the police.
Yes, first will be detailed history. It could be fall also. It could be anything else also. So you have to take history. You have to examine the patient. You have to make diagnosis. Then only any other thing will come. 23-year-old girl, the patient, recent immigrant, attended by ST2. He, because of the fetal distress, your ST2 decided to do vacuum delivery. Patient is stressed and anxious. On communication is difficult. She expressed her request to stop the procedure, but the doctor he did vacuum delivery. What is this
Bad
action?
case.
Yes, bad case.
Bad.
Touching someone without permission could be considered as an assault battery in the criminal and civil law, even if the patient has helped by her actions. Jehovah Witness has an elective cesarean section for placenta previa despite counseled blood transfusion like she doesn't want to have. Despite timely management, patient dies on the table. What is this principle of situation?
Autonomy.
Yes, Harvesh autonomy.
Autonomy.
18-year-old girl come to a pregnancy unit. Suddenly she collapsed. You suspected rupture ectopic. Immediately resuscitation was done, emergency laparotomy was done, and right selfingectomy was done. Patient survived. What is this action?
Beneficence.
Beneficent.
Yes. 83-year-old laparotomy for ovarian cancer. Her family asked, you should disclose the result to them. What is the ethical principle?
Confidentiality.
Yes, because you can't tell them. These are the 4 pillars, except
Justice. No. Veracity.
Veracity.
where you are in the clinic assisted by a nurse. You have a history from a woman complaining of menorrhagia. About to examine her, you're waiting for the nurse, busy with a consultant. Patient insisted that you examine her without nurse because she's in a hurry. She has to pick children from the school. What will be the best course?
Explain that you're required to have a chaperone and will wait for the nurse.
The nurse.
You can't examine without chaperone. You are doing busy clinic with consultant assisted by nurse. You have taken history that woman is complaining of menorrhagia, is about to examine her, waiting for the nurse. No, this we have done. You are on call registrar. Gynae team asked to go to theater because general surgeon wants your assistance. So during diagnostic laparoscopy, appendix appear not. So she was taken in the theater for appendicitis. Diagnostic laparoscopic appendix is normal, but right ovarian cyst is there. There is no torsion. Surgeon thinks that this is the reason for her skin. She has consented appendicectomy and proceed. So what she will do?
Leave
Leave
the cyst. Arrange
for
follow-up in
follow-up.
gynae clinic.
Yes, you will not do any unnecessary procedure. You are on call and postnatal. Okay, postnatal ward. She had a cesarean section. There is when you see this patient is upset and distressed. You explore the reason. She tells you that midwifery staff in the postnatal ward was rude and aggressive. They didn't give her medication. What will be your advice to her?
To contact the local advisory service for hospital patient.
Yes. So if the patient is unhappy, they can make complaint. They can make a complaint. Actually, whenever there is a problem, first of all, you first you have to go to the patient and speak to her. So that option is not there. So next will be complaining. Complaint is done to the patient advice and liaison service files.
Doctor, in answer E also could be correct. We will investigate. Usually, though, we are doing this way. Any problem is there, we are asking, investigating.
No, not to worry that you will investigate further by speaking. Just
All
wait.
right.
Just investigate. So you are not going to speak to midwife.
Yeah. Correct.
You will not do. So
Mm.
no. You this is not your job. There will be incident reporting. Incident reporting, when they do the analysis, then the midwife will be contacted. You are not the person to talk to midwife about this situation. This is few important things, So not very good, but what you can try. 39-year-old woman with 3 children presented in the labor ward with 32 gestation. She progresses with vaginal delivery. Baby is admitted, but following delivery, of fetus preparations is found coincidentally. So what should be the answer? Stillbirth registration. What should be the answer? You can. What?
Scotland stillbirth.
Registration stillbirth not required for
Very
fetus
good. Yes, not required. This is the explanation. So in case of fetus preparations, fetus might have died 24 weeks before. So incorrect to register as stillbirth. A 25-year-old woman with at 23 weeks of pregnancy with abdominal pain and reduced movement. Examination, abdomen soft and closed cervix. Ultrasound, she is no fetal heart. She denies that she accepts death of her baby. She goes back and return back with the pain and baby is delivered. She discharged home next day. So what is the answer?
Abortion Act.
There is no abortion here. Abortion is done for the live baby. "23 weeks." Clue.
Register. Okay.
Not to register 23 weeks. So this is a definition for Stillbirth Act. So a child that is born from its mother after 24 weeks of pregnancy. So in our question, it is 23 weeks. So no registration for stillbirth.
Ma'am, that's okay, ma'am. But the baby is, the fetus is dead and it is 23 weeks. Why can't you register it under an abortion act?
Abortion is for live baby. Hello,
Okay, ma'am.
abortion is for live baby. 23 years old with 2 children at 28 weeks, multiple pregnancy. She is contracting with 10 minutes and 4 centimeter dilatation. Ultrasound scan, 1 twin and 2 twin breech, emergency section, baby admitted. Woman has triplets. Selective feticide was done for one baby at 20 weeks for fetal abnormality. So what will be the answer?
Registration stillbirth not required.
Yes, not required because selective termination done at 20 weeks. Okay, so this is the explanation. 28 years old, in labor ward, unbooked patient. She's having contraction. Fundal height is 25 centimeter. She is unaware of her last menstrual period. USG no activity. She has a return from Africa, treated with for malaria. So what you to be done?
Stillbirth
Here,
and England and Wales.
actually, she is not confirmed. She's unsure of first day of last menstrual period. Previous scan, ultrasound not visible. So you are not aware whether it is less than 24 weeks or more than 24 weeks. So answer is B. Answer is B. Case should be individualized, registered as stillbirth in case of doubt. Okay. 29-year-old woman come from London after summer holidays. Brought into ambulance after complaining of abdominal pain. Fundalitis 39 centimeter. Midwife tells that she can't locate fetal heart. USG, there is no fetal heart. Baby mother is in a denial. She is feeling fetal movement. Next day she delivered a macerated baby. What is the answer?
Stillbirth act.
Tell me the choices.
C, ma'am.
Yes, it is C. There had been an amendment in the definition 1992. So answer will be stillbirth 1992. This is again a good practice paper number 4. Okay. 32-year-old woman with 5 years of infertility for endometriosis. On laparoscopy, you find 4 centimeter hematoma in right infundibulopelvic ligament. What you will do?
J. Perform laparotomy to do internal iliac ligation.
You can't do that.
Call consultant for second opinion.
Very good. Call for her. 40-year-old woman gives consent for sterilization. You have finished it and you find a dermoid cyst. What you will do?
Abandon the surgery and discuss with patient.
What you're saying?
A option, abandon surgery and discuss with patient.
Abandon. But sterilization you will do.
Yeah.
You are not abandoning it.
You have finished the sterilization procedure already. Now you do nothing.
Nothing. Very good. Do nothing. So 19-year-old woman with right ilia fossa pain, diagnostic laparoscopy done for appendicitis. Appendicitis is normal. The surgical team find 3 centimeter simple cyst. Looks benign. They want you to come and remove the left ovary. What you will do?
Abandon the surgery and arrange a clinical follow-up in 3 months.
No, abandon the surgery. No, you will do nothing. They have called you.
Okay, fine, ma'am. Okay.
Surgery is not abandoned because they have already done diagnostic laparoscopy. Surgery has
Okay.
been done.
Okay, ma'am.
You will not go and remove ovary. Patient has tubal occlusion but not had signed the consent, but she had been given a choice about procedure, alternative, risk, benefit, and time, decide to opt for the procedure. So what is this principle? What is this principle?
Informed consent.
Very good. Doctor, this patient developed complication post-operatively, claimed that she was not informed about the procedure. Doctor said that the risks are not discussed according to the standard practice. So what is this principle?
Montgomery.
Yes. This is again this forceps delivered 3.9 kg baby. Delivery complicated by dystocia. Baby has ERP palsy. Mother claims she was counseled about shoulder dystocia. She was not told about ERP palsy. What is that?
Montgomery.
Montgomery.
Yes. Hysterectomy has been performed. 43-year-old woman bled more than usual. Transfused blood. She complained, saying that she had been counseled about procedure, but no one has explained her about possibility of blood transfusion. Otherwise, she would have declined the surgery. So she was not
Montgomery.
given. Very, very good. It is again Montgomery. 16 years old girl, woman, 16-year-old girl, 16 years old partner, termination of pregnancy. They are requesting. They are living together for 12 months. So what to be done?
Obtain consent from patient.
Yeah.
Yes, you can obtain consent from the patient, but before that, Fraser
Assess
is a competent.
competence.
Now you had performed cesarean forceps delivery for distress at second stage of labor. Outcome was stillbirth. Case was referred to coroner. Coroner is asking for medical report. What will be the right choice?
Release information request.
No need to seek permission from release without the need for permission from patient, but with permission. D option.
Release the permission requested, and this is the explanation from GMC. So I put it from GMC website. So disclosing the information after the patient has died. Your duty of confidentiality continues after that. The circumstances you must disclose the relevant information about the patient when disclosure is required by law to help coroner, fiscal, or similar professor with an inquest or fatal accidental inquiry. This is the from the GMC website. Is it clear? Is it
Yes,
clear?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah. Therefore I'm gathered all the pictures so that 15-year-old woman with in gum clinic with vaginal discharge. She is presented with 19-year-old boy partner. She has STI. What you will do? So 15-year-old girl, what you will do? So something has to be with what?
Competence.
Ensure competence.
Yes, it has to be Fraser incompetence and
Treat and encourage her to tell the parents.
yes. So P is the better answer.
Ma'am, I
Basically, you
doubt
have yes.
in that abortion, the previous question, why can't the answer be P, ma'am? Not
There
this
we,
one. Previous.
what you are saying? Why can't we answer P?
Uh,
It can be P also. Basically, this is this is the question from this Conji, and their options are wrong, so it causes confusion. So you should know the right thing. So basically you have to do assessment for Fraser competency, and you can give them treatment, but you encourage them to tell parents. So you should know, you have to check for the options, but if they don't go for the Justin Conji options. Their options are not right. Okay, it is P only. It is P only. Okay, so though we have done abortion class, but I put some question. 27 years old woman brought into ambulance at 24 weeks. Blood pressure is 165/100, very irritable, blood pressure, protein 4 plus. Biochemistry result, very raised ALT, urea, uric acid, thrombocytopenia. She commenced on intravenous levodopa magnesium sulfate. So what is the circumstances her pregnancy can be terminated?
Clause A.
F.
Clause
F.
F. Why?
A. A.
Yes. Clause F, when there is there is a risk to life of mother, but it is on the emergency. Right now there is no emergency, so A will be the answer. Okay, A will be the answer. It is for the mother, but there is no emergency, so answer A. So
But she
19
has
years.
currently BP of 165, 110. So we can't wait so much to terminate, no?
Yeah,
So
therefore
she is already in ambulance.
yeah, see, it is done in emergency, like emergency, what should I say, like she has come and she is bleeding excessively, some trauma, some accident. Okay, so that time it becomes E. But right now she is okay, a bit stable patient, but the medical condition is there, therefore continuation of pregnancy will do harm to her. So therefore is the answer A. Is it clear?
Yes, ma'am. Okay.
So this is emergency and this is non-emergency. So 19-year-old wishes to termination at 10 weeks because her boyfriend doesn't want to be a father. So what you will do?
C.
Abortion in yes, C. Specialty training collecting data for research product. He scanned the copies and he saved in unencrypted memory stick. He arrives home and she is not able to find memory stick. What will be the right thing?
Refer to medical director.
Caldecott guardian.
Caldecott guardian. Caldecott guardian is basically Caldecott guardian is also a medical director from the hospital. But if they have given answer in the as a Caldecott guardian, so that will be the best answer. Fetal medicine specialist performs amniocentesis, and 2 days later the patient has miscarriage. Midwife feels that he has got very high rate of miscarriage. What he will do?
Audit.
Very good. So audit is a quality improvement process. You will do audit to keep check on the practice that you are doing. Woman admitted for cesarean section. During course, she had cardiac arrest, not possible to resuscitate her. She has amniotic fluid embolism. What will be the answer?
Incident review.
Refer coroner.
Coroner. Incident, yeah, it will be incident reporting and root cause analysis, but here that is done for everything. From here, only thing that is applicable to this will be coroner. Now, last couple of questions are there. These are from strategy. So, couple is referred to fertility service because 20-year-old male has testicular cancer, and he will require chemo and orchidectomy. So, they wish to restore semen for the artificial insemination of his wife. Because he will be azoospermic in future. So, what should be the answer?
Written consent must be obtained.
Yes, written consent must be obtained. 13-year-old girl requires hymenectomy to treat for cryptomenoria.
User competence must be demonstrable before obtaining consent.
So there should be Gallic competence, but I think there is no option of Gallic competence. Gallic competence is not there. Okay, so it can be done with a paternal person who has got parental rights. Okay.
Okay.
14 years old girl attend gynecology, this you know, for termination. She doesn't want her parents to know. You know this very well. What is for termination? It is?
We can proceed without the need of parental consent. Only patient consent is
Fraser
sufficient.
guideline, Fraser competence is demonstrable before obtaining consent.
Effective.
19-year-old girl with Down syndrome, gynecology clinic. She requires exploratory laparotomy. She is an orphan. She is living in a residential area. She has got low IQ. So for laparotomy, for what to be done? She requires laparotomy. She has got no capacity. She lives. She's an orphan. Who will consent? Who will you will involve? This you have to at least tell me. So if you have to do any treatment, patient has got no capacity, what you will do?
Legal
Best
advice.
interest.
Very good, legal
Best
advice. No, best interest will be in emergency. Best interest in the emergency. And like here, there is no emergency. Here, problem with the capacity. So, okay, you are doing any treatment. So legal advice to be required. this you already know. 19-year-old girl, 18-year-old woman to be seen by consultant gynecologist who is accompanied by medical student as a part of clinical attachment.
verbal consent alone is acceptable.
Yes, verbal consent is alone is acceptable. So 39 years old woman with for surgical termination of pregnancy, insertion of marina she has been consented 1 week before, but now she is she upset and she doesn't want to undergo. She is reluctant to undergo procedure. So what you will do?
Respect the rights of the woman to withhold the consent for treatment.
Respect the rights of women to withhold consent for the treatment. Yeah, that is also right. But you are going to do some surgery. So what you will do? You will defer the operative procedure. Today you will not do anything. But you are saying respect the right of women to withhold consent for treatment. This is also correct. Because this is O is also right and B is also right. Both are right. You have to respect the patient can withdraw consent anytime. Okay, but answer given in the strategy is defer the operative procedure, but both are right. O and B both are right. Okay, thanks for that. Thanks for joining. Any one of you have got any question can ask me. Any
Thank you, ma'am.
question? Okay, welcome. Someone was asking some question about transverse lie. Have I